I'm Dr. Tyson Morostica.
And I'm Dr. Derek Moore, and we are your sports quacks.
All right, welcome back, Sports Quacks. So today we're going to kind of jump into peripheral nerve entrapments and nerve issues, and basically what can you do for patients that have come into your office and they have neuropathy, or they've been they've been diagnosed with neuropathy, and nothing seems to help. So that's something that I see actually all the time in my office. I'll get patients who come in and they'll have numbness, tingling, pain down into the legs, into the feet, and the hands, and they'll be wondering, well, what is this? Oh, well, it must be related to, diabetes. Well, I'll go, are you diabetic? Well, no. Well, then you don't have it. Or it's not going to be related to it. Or things like that, or vitamin deficiencies. People try everything, and you'll find that you're actually the last person they'll come to, and that's okay. Because I like batting cleanup. I like being the last. I really do. And so here's the thing. The most important thing that I see is a history. So number one, are you taking a proper history, and then number two, are you following it up with a proper examination? And I say this all the time. I mean that's I do it all the time, but examining the whole track of the nerve. Are you asking questions about where the numbness, where the tingling is, or are you just taking it, oh, they've got numbness, tingling in their hands, so it's got to be a nerve root, and I'm just going to smack it. There's a real beauty when it comes to the diagnosis of nerve issues, and that's actually something that I will give a majority of the credit to ART, and why I've been successful with these type of cases is because the beauty of understanding nerve entrapments, peripheral nerve entrapments, I mean, it's amazing, and being able to use that in clinic, and it's wonderful because it's something that doesn't change. Like, it's something that is what it is. What are common entrapment sites doesn't change through time. So Derek, let me jump over to you. When I talk about patients with neuropathy, and what does that say to you? What does that draw out, thoughts and feelings wise, essentially, right away?
Yeah, so in case we have I'm hoping some new listeners, I'm usually always excited for a disc injury, and for me, disc injuries have become a little bit easier to manage. So it's just because I've been trying to really dive deeper and deeper into it. So generally what I'm going to go with is they would say some type of neuropathy. I was like, okay, when you say neuropathy, because most of the times patients don't know what that is, it was just, if a patient comes in and tells you that they had neuropathy, they got it from the internet or somebody told them that they have neuropathy. They don't know what it is. Sometimes if it's an older patient who's diabetic, as Tyson brought up, sometimes that patient will know because they dealt with it. Mm-hmm. But always ask them, all right, what do you have actually going on? And they'll mention oh, I have pain running down my leg, or I have numbness and tingling going down my leg, or my foot just feels like it's asleep. My leg feels heavy. Different explanations from the patient is always, and descriptors are always what I'm looking for, just so I can get a better idea of, okay, is this matching up, or is it with a disc injury? Is this matching up with something more internal, like a diabetic neuropathy, or is this looking like a nerve entrapment site? For example, when they're telling me that they're having some pain and numbness going down their leg, and then it kind of and it never goes past the knee, and it kind of just dies out in the hamstring, but it's really, really pronounced right in the glute. And it's like, okay, we go through some MDT, we do some extensions, we go into flexions, we do some spinal motions, doesn't seem to make any big difference. Well, then we'll get back on top of what we always talk about. We start looking at the hips. We start to recreate some of the sensations by moving the hip in certain directions. Now I'm starting to think, all right, this might end up being more of a hip issue and more of a nerve issue getting stuck somewhere within the hip, let me go down that rabbit hole a little bit. And a lot of times you might end up finding that, okay, um, some of the rotators are in spasm. Generally, the piriformis or is usually that kind of that go-to. Oh man, like this lights them up and makes the sensations even worse. And a couple of passes gives you that magic touch. Feels a lot better right away, and you're like, oh, all right. You don't have that disc herniation. That weird sensation that you're feeling down your leg wasn't due to the stenosis that they saw on your X-ray. It's actually more of just some hip tightness and stiffness where there shouldn't be. And just by going through some quick exams, a lot of times we can start to re-diagnose the patient versus just sticking with their walk-in diagnosis. And I think that's kind of the big game changer at the end of the day.
Yeah, I think that's it too. I like what you said there when you talk about your progression of your diagnosis. Like, okay, I'm going to rule out, essentially, I'm going to rule out what they think they have. I'm gonna rule out a possible disc injury or some sort of spinal cord issue. Then I'm going to go and I'm going to work on peripheral. I do things. I would say that's essentially how I do them as well. Like I really do like the seated stuff, like doing a Kemp's. That's what it's called, right?
Yep.
Yeah, Kemp's is the extension. Yeah, and I like that, and I know that I do know that is more of a facet test, and I get that. But I also like asking about things. I really do like the coughing, sneezing, anything like that, sending pain down the leg. I think that stuff's important. I really do. Now, let's go over some. Let's go over nerve. Let's just go over pure like nerve stuff in the hand. Like let's just talk diagnosis in the hand, right? So, patient comes in, and they've got numbness and tingling in the hand. And if you're a student or you're another chiropractor, I hope that you're asking me the question, where? Because where it is extremely important. Is it in the first three fingers? It is meaning thumb, index, and middle finger. Is it in the ring or the pinky, or is it the back of the hand? Number one, if somebody comes in and tells me that, I'm more likely to jump on peripheral entrapment than I am to jump on a dermatomal pattern. And that's something to me that I find is consistent. Dermatomal pattern pain seems to be inconsistent, because if that's the case, I should be able to, flex, extend, move the neck in a way, and it should create a line right down to it. And rarely do I see that, even with disc injuries. Like rarely do I see that follow like that perfect dermatomal pattern. and I just don't. I guess to me, I just never really liked that. However, I really do. Every time that I test a peripheral nerve, it holds true. Like if I want to go someone and I want to stick my thumb right into their pronator teres and I want to hold it there for a second, guess what goes numb or guess what begins to tingle? The first three fingers, the thumb, index, and the middle, and it's always on point. Or if I want to check, right around the elbow, medial elbow for the ulnar nerve, and I want to do a tap test, guess what lights up? It's that pinky and that ring finger. So for me, those always hold true. So when somebody comes in and they're like, hey, I have it right here, my first thing is I really do lean more towards entrapment sites. So I'm looking and I'm working. Now then we also have to decide, what direction do you move? Do you move peripheral to
proximal, distal, proximal? Yeah, right.
And that's also a beauty in itself too. And to me, I think I actually tend to work more distal to proximal, because I can light the nerve up depending on where it is. I have found that it holds pretty true that if I work entrapment sites, and where it recreates tends to be where the problem is, like what tends to be where a double crush type problem is, or where the whole problem, the real problem is. And I don't know if you see that, Derek,
Yeah.
but that's what I
You know,
see.
like, yeah, what's odd about that, like now that I sit back and I start to think about how that works, I generally go proximal to distal for lower extremity, but upper extremity, I usually will go from distal to proximal. Like anytime somebody's coming in and they're saying that they have numbness or tingling in their hand, usually I'm starting to say, okay, let me check your forearms, and then I might start checking into the neck. Sometimes I'll look into the upper arm, maybe like coracobrachialis
Mm-hmm.
and stuff like that, and then sometimes I might go into the shoulder subscap, just getting seeing into like the axillary nerve and some of the bigger roots there. But I'm telling you, like Tyson hit it on the head. Like that's what I get all the time when talking to patients. I have carpal tunnel, and it's like, okay, where do you feel it? Oh, I only feel it in my pinky. I'm like, that's it? And it's like, yeah. And like, yeah, and sometimes I can feel it in through my forearm, especially when so he was a plumber, and he was just always doing something weird with his grip, just working on pipes. And he'd say at times he'll just feel it numb, and he'll kind of shake it loose, and then he'll feel fine. And just going through his flexors, you can kind of just feel the amount of tension that he was holding through there. And I was just pressing through flexor carpi ulnaris. That was it. And he was just like, oh yeah, I'm starting to get some of that numbness back. It was like, I'm like, all right, man. Like, we just did a few passes. The first pass was pretty intense for him, and then we started to lighten it through, and 3 or 4 passes later, he's just like, my arm feels better. Like he was describing it as if he didn't feel as though he had two different hands, and that's what he was kind of experiencing. That his hands just didn't feel the same, and as we were going through the treatments, we just really just kind of worked through a lot of that stiffness, and then I showed him how to just start to administer some self-stretching, some very, very light nerve flossing onto the wall, and it really seemed to kind of give him the relief so that he can continue to work. And a lot of times I'll start to see some strange diagnoses, especially on TV, and I'm wondering if people are missing the boat. Tace, I don't know if you've seen this, but so I'm a Red Sox fan, so I'm all up to date with what's going on with the Sox. And David Price, for like the past year, has been having these huge forearm issues where they're saying like he has carpal tunnel 1 week, and then they're saying he has a strained flexor tendon, and then they're saying he possibly needs Tommy John surgery. And I'm just wondering, I'm just like, what's happening there?
Oh my gosh.
Like it's all like, as a clinician, you're hearing this and it's like they're beating. They must be right around it. They're just like,
Yeah.
all right, is this? They've given him every single diagnosis that it could possibly be, and I'm just wondering, I'm just like, all right, what is he actually feeling? What is he
I
experiencing?
know.
Because when you're having that, I'm just like, okay, that's what we go through as clinicians. All right, this is what they're presenting with. Is it an elbow problem? Is it a forearm problem? Is it a wrist problem? And then you kind of just start to work from there. And many times, a lot of these patients, they just see it as just it hurts where the problem is in the hand, so it must be a hand issue. And as clinicians, we have to explain that to them. So, Tice, when you have a patient and they're saying they have carpal tunnel, and you press through pronator tears and you see that that's where that median nerve is getting really hung up, how do you walk them away from that diagnosis? Because sometimes patients hold on to that diagnosis of like, wait, so you're telling me I don't have carpal tunnel?
Yeah. It's so first off, didn't David Price miss a start because of Fortnite? Because he was gaming? Is that true?
Listen. No. So he said he didn't, but it was because he was having that numbness and tingling into his hand. And then they were saying like, oh, he's having numbness and tingling into his hand. He's an adamant Fortnite player. Like he said that he's done it. I don't know if he streams or not, but he says that he plays often. So people are like, because I think he plays in the clubhouse. I think that's what.
Gotcha. Oh, okay.
And then they're just like, oh, he must have carpal tunnel because he plays Fortnite. And I'm like, guys, like leave him alone. They didn't have any problem with like Kevin Millar and Manny and Manny Ramirez taking shots of Jack and eating fried chicken back there. You know, I was just like, if he wants to play Fortnite, I'm fine with that. Like, go let the dude play with some 14-year-olds and get his frustrations out.
Oh,
Right?
that's hilarious. So let me jump on that question though. So that is something actually amazing. I have seen you'll actually so if you are a new clinician or if you're a student, you'll be amazed in the future how many patients come to you say I had a carpal tunnel release surgery and it didn't help me. We all see it. And I get why they do it. I'm not saying that it's uncommon.
Yes.
Yeah, like I get why they do it. I mean, but here's the thing. All those patients that have that, I've tested further up the track, and it's always there. Most often, I see carpal tunnel issues with pronator teres. Derek just said it right there. It's the culprit most of the time. So how do I explain it to patients? And I think it's explaining the anatomy, taking a step back, walking them through it, putting my hands on them. Because if you have really good tissue feel, and I'm not saying I'm perfect, like I'm not saying like I've got like this unbelievable but amazing skill, but what I'm saying is that if I'm working through a patient and I can correctly locate the origin and insertion of pronator teres, I can literally walk down, and if I'm pressing light enough, I can feel the bump of the nerve. I can feel where it goes, and if I apply a little pressure, it'll zing them. It'll zing their hand, and I know it will 100% of the time. So it's always important to really get my hands on patients when I'm explaining things. I rarely draw diagrams. I point to posters that I have in my room, but I really like getting my hands on patients because I think when they connect that and they can feel what I'm doing and I can explain while I'm doing it, it makes more sense to them and it allows them to kind of separate themselves from that incorrect diagnosis.
And sometimes it's as simple as if they don't believe you, you press on
Light
that
'em up.
median nerve pronator because it honestly we know that it's not going to do any long-term damage, but sometimes if they really just attach to it, it's like, hey, listen, I'm going to press here. Let me know what you feel. And then you press it, it's just like, oh, I can really start to feel it. And it's like, okay. And when I take you through some of that motion, does it get better, worse, or no different? And many times, like Tay said, you'll notice that they'll say like, oh, that's really starting to lighten up. I don't feel it as much. And then you'll find as long as you continue to really, and I like to use ART as just a different type of loading mechanism, and everybody says load, load, load. Like this is a different way that you start to load it, and especially for a possible nerve entrapment, you don't want to overextend with anything. Man, it makes such a huge difference in such a short period of time. And the relief, I think one of the biggest issues is the relief that they get is great, but then you have to also kind of explain to them why they had the surgery.
Mm-hmm.
And I find that to be sometimes one of the more harder discussions. When you get that patient and you're explaining to them why they need a certain exercise, why their pain generator is in their forearm and not in the carpal tunnel, and why you were able to diagnose it versus the other the chiro or the surgeon, right? And the hard part is you have to be empathetic. You have to kind of calm them because a lot of time what I deal with is a lot of times they're just frustrated and angry because they felt as though they were lied to, and many times they're just like, hey, listen, like this is where we're at now. We found the issue. Unfortunately, like you went through all these different hoops to get there, but it's a good sign that we can now kind of fix this issue. But as clinicians, I think we have to start to get a little bit more thorough with our exam, because if they're on that cusp of surgery and it's not going to help, we really, especially as chiros, I think we're really that last line of defense.
See, but that's a great thing about the skill that we have there and the knowledge that we have there, because when it comes to other healthcare providers, they tend to play on the percentage. So actually, let me take that back. When it comes to more medical world, they tend to play the percentage game, right? Where uh, if you go in, you have numbness, tingling in your hand, 75% of the time it's carpal tunnel, right? Or 50% of the time, 60% of the time it's carpal tunnel. Well, the majority says that it's carpal tunnel, so I'm going to lean more towards the carpal tunnel.
Mm-hmm.
Then you have other people that are just led by their heart completely and end up chasing these wild diagnoses that are out there and can never find the answer. But then I feel like you have us as chiropractors and also physical therapists too, where we use the statistics, but we also use our palpation skills. We use our clinical experience. We use uh, more of the what we've seen and orthopedic testing to build our diagnosis. And I think that's what can make us far more successful. So having tools like ART's diagnostic breakdown, their diagnostic algorithm, so having a simple tool, just a knowledge of that tool really changes the game when it comes to the diagnosis of those problems.
Right, and it just gives the clinician a nice safety net of, okay, this person is lining up for surgery. I'm going to be that person that is going to be the decider of whether or not this person goes to that ortho. And if you're just like, okay, you've had manipulation that hasn't worked in the past. You went to massage that hasn't worked in the past. Let me try this ART protocol and see if we can make a difference. It's always just nice to have these techniques in your back pocket because like we keep harping on, where many times that last line or where the person that they failed everywhere else and then they're coming to you. And a lot of times you can start to ask them, all right, what did you have done? And man, it's the most frustrating part for me is sometimes that it's like I've had adjustments, I've had heat, ice, stim, PT, exercise, stress, stretches, exercise, nerve flossing, and I'm sitting there, I'm like, okay, so that's everything that I would probably have done for that too. What else did they miss? And that's when you go into it, like, okay, we'll do some of that nerve track stuff that we discussed with ART, or we'll do some Mackenzie, and having that extra knowledge for some of these peripheral nerve entrapments, and then also having a solid basis in the anatomy, you'll start to be able to kind of put together some of the missing pieces to that puzzle and hopefully figure out what that primary cause is. And we talked about this a few podcasts ago, and I recommend you guys listen to it. The anatomy knowledge is extremely important, vital when it comes to making these diagnoses. And it's just like, hey, yeah, I have sciatica. Okay, where do you feel it? I feel it on the front of my thigh. Cool. You don't have sciatica. That's anatomy 101, but
Yeah.
I can't tell you how many times I'll look into some other notes from clinicians and there's a sciatica. Patient presents with radiating pain in anterior thigh. And I'm like, dude, where's your sciatic nerve? What's going on there? And we laugh and we're just like, who would do that? But I'm telling you, when you're in the field for long enough, and it doesn't even need to be very long, you'll start to see some of these diagnoses, and you're just like, okay, let's just go back to some of the fundamentals and see if we can figure out what's actually going on here.
Well, and so you brought up an interesting point there. So with common misdiagnoses, here's one I really want to talk about. If you have, say we're going to talk neuropathy, right? Neuropathy is a big word, right? A big a big thing right now going on with, but I believe an overdiagnosis, and it's going to grow in the future because of the amount of patients that we're seeing that are diabetic. I know that we're seeing I'm going to just make this point quick. I know that we're seeing a spike in diabetes, and I know that we are all, we worry that we're headed that direction. But the younger generation is actually showing less signs of diabetes. So it'll be interesting to see the older population kind of wean out. But we are going to see, for us, more diagnoses of diabetic neuropathy type cases, just because this older population is unfortunately getting bigger and bigger and more diabetic. So I think that's a diagnosis, more and more diabetic.
More and more diabetic. You are
Yeah,
the
I
most
like
diabetic in the world.
I
You
like
and
that.
Wilford Brumley are the most diabetic in the world.
I'm going with it. So here's the thing. So when it comes to diagnosing these things, you have to really look at if a patient comes in and they're like, oh, I'm diabetic and I have numbness and tingling in my right foot. Is that because of their is because they have a diabetic neuropathy? Probably not, because you would expect to have it in both sides. One of the things I love to do is to see patients who have been diagnosed with stenosis or diabetic neuropathy, things like that, and they only have symptoms in one side, and then get to explain to them, no, you should have symptoms on both sides. That's what that diagnosis is. If you don't have that, it's something else. And so I don't know if you've seen that a lot, but that's something that I actually really enjoy working with because it changes people's world. I think it's a cool thing to do.
Yeah, and it's sometimes like we were discussing it by showing them that hey, this diagnosis might be might not be exactly correct. The patients will start to be like, okay, so are you telling me that I could possibly be symptom free? And it's like, you know what, you possibly can't. And that can reinvigorate them enough so that they can try for more care. Because if they've been through the ringer and been seeing multiple clinicians, a lot of times they're just going through clinician fatigue. They've been through everything and they're just like, can you just give me a pill to just get this, to get me off of this? And they'll go for that gabapentin, they'll go for those nerve blocks, they'll go for corticosteroids, whatever they can, because they feel as though the system has failed them, and in many cases it has. So we can't allow for that to really frustrate us and really start to look at them and be like, okay, diagnosed with stenosis, nothing matches up. So what does match up?
Mm-hmm.
And then explain to them why this diagnosis is slightly different from their original and how your treatment is going to be different. Because at the end of the day, too, sometimes I'll listen to people explain things. It's like, okay, yeah, you don't have a segmental dysfunction, you have a facet issue. I'm like, all right, how do you fix that? You adjust it. I'm like, all right, so who cares? You know, it's not. We're not talking. It doesn't change your treatment. But when we're changing a treatment from saying, hey, you don't have diabetic neuropathy, you just have some peroneal nerve issues. We can really just start to fix this by just working through your lateral leg, and a lot of that will actually start to dissipate. And it's like, oh, okay. So original therapy was blood work, figuring out you have diabetes, now you're on insulin, versus like, oh, few treatments of a few passes on peroneal nerve, clear that up, strengthen the fibular muscles, and you're good to go. And they're like, oh, that's it? That's it, hopefully, you know?
Yeah.
And sometimes it's just a lot more gratifying for the clinician when you can just be like, all right, I finally hit it. You know, like this we're starting to build something from this versus just getting, because I've been there, I'm sure you have been there too, Tess, where you're working on that neuropathy and it just doesn't seem like it's getting any better.
Yeah.
And that's when you start to kind of go through your head, just like, okay, did I miss something? What are their next steps? And as clinicians, we got to put our ego out the door. And if we think that we missed something, who can figure out what we missed? And if they're really on that door for possible surgery, who are we going to send them to? Because we can't hold on to our patients just because we can't figure it out.
Or to just make money. So I've been seeing this a lot lately, where I'll get letters from programs or whatever, where it's like neuropathy, you know, how to treat neuropathy in your office, and they set up these like big long programs of like diet adjustments, different work, and you sell them like these big like $10,000 packages. If there's any of our listeners out here who do that, I'm going to tell you from the get-go, I don't really have any interest in doing that, but I would like to learn what you guys do. I would actually be interested just to hear it out, because that's one thing that I'm offered is, oh, we'll talk to you about how to do it, but I don't want to be on a big sales pitch because I'm probably not going to incorporate it in my office. But I would really be interested to know how a chiropractors and diets and and a strict regimen of adjustments would help a patient. So yeah, if you're someone who does do that, let us know. I'd love to have you guys on the show or talk to you. I think it would be a lot of fun. So that's something I've seen. I don't know if you've seen that, Derek. Have you had that? Have you seen that
Yeah,
out there?
yeah, and so I always think that there's going, especially for some of these chronic issues, and that there's always going to be possibly some type of nutritional issue that's going on with patients. So, I mean, I feel as though a lot of the research is still up in the air when it comes to what are inflammatory foods, how's your body going to react. Every day it's keto's good, keto's bad, do the carnivore diet, just eat meat, go vegan, never eat meat, go paleo, only eat certain meats. And it's like, and I think it's on a spectrum. For most times I would just look at a patient, and many times they know if they have a bad diet.
Yeah.
Like they don't need to be told. And usually I'll just tell them, like, hey, listen, your weight might be playing a role into this. So if we tried to figure out how to clean up the diet, that might help you. But I'm not going to sell them a meal plan. I'm just going to help them along for the ride. And then if they need more help, whether that's they need to have their meals planned out for them, they need to have a nutritionist, they need to have a food allergy check or something like that, I can direct them towards that. But I'm not going to be their nutritionist. I'll just let them know, like, hey, I think what you're eating may play a role in some of these symptoms, and your weight might play a role in some of these symptoms. And sometimes clinicians just don't do that. I had a woman who was telling me, just like, and she was a little bit heavy, and when I told her, it's like, hey, I think your back pain might be a little bit due to some of the weight that you put on recently. She was just like, yeah, I've just been going through some hard times. I've just been really struggling, kind of controlling what I'm eating. And I was like, this is a time where we can start to make some corrections in your like biomechanics. But if we don't control what's going on with kind of like your stressors, which is basically what's going on with your head and what you've been doing to cope with it, you might kind of continue this cycle. And it turned into more of like a psych kind of counseling session versus a treatment session. But some patients need that. And you'll be surprised when you start to go into some of these other factors, how much they can have a change into them. But I'm not selling them packages. I'm not putting them 3-month detoxes and stuff like that.
I know. I'd be interested. I'd be interested to see how it works. Like I kind of feel like that Joe Rogan kind of like position where it's like, just come, let me talk to you. Like I literally like want to. I would
know nothing. Just tell us what you know, and then let's see where we go from there.
Yeah, just feed me, because I'm a skeptic. But feed me. I'd love to hear it. So, let's wrap up on that. Honestly, I mean, here's the thing. When patients come in with a lot of nerve type symptoms, the diagnosis is obviously key. The examination is crucial, but using your best clinical judgment allows you to have the best results. So, and I think if you understand your anatomy, you understand the way the nerves travel, you don't have to do techniques like ART, but if you know it, you have it down, then you're going to have a great success with it. But also, look for the key words and don't be afraid to be specific. We don't need to generalize nerve diagnoses. Don't be that person. Go in, do the full exam, find the exact nerve that's the problem, and include it in your diagnosis. So like always, this podcast is to help, you guys, help us, help us grow, help us, Derek and I grow as practitioners. And so if you guys have, we'd love to, listen to you guys. If you guys have stuff or, things that you're doing in office for neuropathy or for peripheral nerve entrapments, would love to hear it. Send us some messages on Facebook, hit us up on Instagram, and let us know what's going on. We'll talk to you guys later.